So all of you are able to see the slides, able to read these questions?
Yes.
Yes, okay. So can anyone start with this question?
Okay, I'll just go first. Can everyone hear
Yeah,
me?
yeah. Yeah, don't worry. If you make a mistake, it is well and good, because we are all here to learn. Okay, so just attempt. It will be good that you will be learning something new. Okay.
40-year-old male complains of feeling very low in mood and having lost interest in his usual activities over the previous 6 weeks. On further questioning, he also expresses some ideas of wanting to harm himself and having thoughts about suicide. What is the preferred first line choice of medication for this patient?
Okay.
It's a 40-year-old patient, low in mood
Okay.
and no interest.
Yeah. So you can. So let us understand first. What is the diagnosis here?
I
What is
would
the
say
diagnosis?
depressive with suicidal tendencies.
Yeah. So no. What is the name of the diagnosis?
Depression, sir.
Depression. It's clear cut depression, because patient has lost interest in the daily activities. He has got a very low mood, and he has got suicidal ideas, which will place him in a severe depressive disease. Okay. So in a patient with depression, so what they're asking is, what is the first line treatment of depression? This is as simple as that. Okay. So unlike NEET exams, where they're going to ask one liners, okay, the part one exam or MRCP exam would give a scenario, and they would be asking a question based on the scenario. Okay. So this patient has depression, and they're asking what is the first line drug for depression. That's all. So what do you think is among the drugs? So how it is different from NEET exams? Okay, there are 5 options here. Okay, and among the 5, one of them will best fit the scenario. Okay, so it's easy to rule out. There are no negative marking here. It's easy to rule out 1 or 2 options. Okay, now if you look at the 5 options there, which are the drugs which definitely not used to treat depression?
Lithium, it's for
The-
bipolar.
Yeah, so
Yeah, bipolar
yeah,
disorder, yeah.
lithium is bipolar means they should have depression along with mania. Okay, the scenario
But
does not talk about manic episode at all, so it's a plain depression. So lithium is definitely out. What is this olanzapine?
That's an atypical
atypical
antipsychotic,
antipsychotic.
Yes,
right?
excellent. So olanzapine is an atypical antipsychotic. Here the patient is not having any psychotic episodes or psychosis. Okay, he's having mainly depression, so you're not going to use. Okay.
So this
Now,
is,
so this is how you have ruled out D and E. So you have 3 options. Okay, is it tricyclic antidepressant? Is it monoamine oxidase inhibitor? Is it SSRI?
Sir, I would like to go with it.
Yeah.
Sir, TCA, monoamine oxidase inhibitors, they are not anymore used, and SSRI is a choice in cases of depression. So I'd like to go with the option C, sir.
Yeah. So the monoamine oxidase inhibitor are no longer as clinically effective as others. Okay. So if you look at our MBBS curriculum, you would find that the commonly used antidepressants are either belong to tricyclic antidepressant or selective serotonin reuptake inhibitors. Okay. Now the question here is, the patient has what is known as suicidal tendencies, isn't it? That means he is at a risk of taking additional medicine. So whatever medicine you are going to give, he may consume that in excess dose. Are you able to follow this?
yes, sir.
Yes. So which
Yes,
which
yes.
of the two class would be more dangerous if you give an excess dose? Is it tricyclic antidepressant?
Sir, SSRI would be dangerous, sir. No, SSRI
SSR,
would be dangerous, sir.
SSRIs. Okay.
Yes, sir.
Any other opinion?
Yeah, I think TCA would be more.
Yeah. So remember, tricyclic antidepressants are older drugs. Okay. They have they have multiple action. They are like anticholinergic, anti-dopaminergic. Okay. They have antihistaminic properties. Okay. So they can cause sedation. They can cause cardiac arrhythmias. Okay. They can cause acidosis and so on. Okay. So tricyclic antidepressant example, I think commonly one which we know is amitriptyline. Do all of you remember, isn't it? We prescribe for peripheral neuropathies or headache. Okay, the amitriptyline. Okay, so it is a dangerous drug. Okay, so whenever a patient has suicidal tendencies, there are two things which are important. One, whatever drug we should use should have a high efficacy. Okay, whatever drug we use should have low risk for toxicity. You understand the two concept?
Yes, sir.
Yes. So because the patient has severe depression, how do you know patient has severe depression here? Because patient has suicidal tendencies. Okay, so whenever a patient has severe depression, you would choose a highly effective drug, and you would use a drug which is not that toxic, okay, or does not cause that much side effect. Okay, now because of these two reasons, SSRIs are preferred. Is it clear?
Right.
Okay, so SSRIs are drug of choice for patient with severe depression. Okay, so can you name one or two SSRIs?
So citalopram,
Yeah, citalopram, sertraline. Okay, sertraline is the one
fluoxetine,
which is,
paroxetine,
yeah, fluoxetine, peroxide. These are commonly
mirzapine.
used both. Yes,
Sir.
these are used in both neurology and psychiatry. So remember SSRI, two, three important points about SSRI. SSRI, we always started with the lowest dose. You have to increase the dose every 2 weeks. Okay, the patient should come for follow-up every 2 weeks, and every 2 weeks you'll increase the dose. Okay, maximum you will try for 3 to 6 months. Okay, if there is no response in 3 to 6 months, you would switch to another SSRI or switch to another class of antidepressant. Is it clear?
Yes,
Yes.
sir.
Right.
Sir, I have
Yes.
a doubt, sir.
Yeah, please. Yes, yes.
Sir, in SSRI, we know that after initiating SSRI, the
Yeah.
chances of suicide is highest in the first 2 weeks. If I'm not wrong, sir, please correct me. So, will it be a safer
Yes.
option to go with the SSRI in a patient who's thinking about suicide?
Yes, see, that's what I'm saying. SSRI are more efficacious than TCA. And
Okay.
any antidepressant for that matter, we are going to always start with the lowest dose. Okay, there is optimum dosage is based on the clinical response. Okay, so we always start any antidepressant with the lowest, even antipsychotics. We always start with the lowest dose, and we gradually increase the dose. Okay,
Okay, sir. Okay, sir.
is it clear? Shall we go to the next question?
Yes.
Yes. So we are
Yes,
going to
sir.
discuss few of these questions, so which will give you the approach how to go about this solving these exam questions. Okay. So that will help in solving more questions when you go through them independently. Okay. So we're going to skip this. It's not that great question. So I'm going to go through some of the important questions. Yeah. So this is about diagnosing a condition. Okay. Can somebody go through this question?
Okay, I'll go ahead, sir.
Yes. Yes.
A 45-year-old woman attends her GP surgery complaining of poor sleep. On closer questioning, she says she avoids leaving the house because she is scared of people looking at her. And 2 weeks ago, at a restaurant, she had an episode of tachycardia and breathlessness with intense fear. What is the likely diagnosis?
Yeah.
Options A, agoraphobia, B, depression, C, generalized anxiety disorder, D is panic disorder, E is social phobia.
Social phobia.
Okay, so I think the first option is like she's scared of people looking at her. So she's obviously having a phobia, sir. And
Okay.
she had tachycardia and breathlessness with intense fear.
Okay.
So looking at the options, sir, all the options. Oh, my screen went off. Wait a second, sir. Sorry. Uh-huh. So, sir, depression is not there. Definitely, the B option is ruled out. And C option, generalized anxiety disorder, it looks more than that because she's phobic. So B and C options are ruled out. And
Okay.
agoraphobia, I'm so sorry, I do not know anything about it. So I read it, but I have forgotten it. So
Agoraphobia is the fear of crowds.
Yeah.
okay. So it doesn't seem like that she's having fear of crowd. She's just okay. She's scared of people looking at her. Basically, yes. So there is a hint of she's scared of people as well. So it
Okay. So
might
what does?
be, it doesn't look like a panic disorder because she's not reacting intensively, something. So
Okay.
it might be E or A option. It could be social phobia, it could be agoraphobia, sir.
Yeah. Yeah. Okay. So that's a good analysis. Okay. So this is how you have to derive at a diagnosis. Still, you have 50% chance of getting it right. Okay.
Yes.
So let us go to the individual option. So what is you have doubt between agoraphobia and social phobia, isn't
Social
it?
phobia.
A and
Yes.
E.
Yes.
Yeah. So
Yes.
agoraphobia is basically a fear of being in a particular situation. Okay. It may be open spaces. Okay, for example, you are trapped in a lift, or you are trapped in the sense you are being watched, or you are there in a train or a big crowd. Okay, so that is known as agoraphobia, fear of being in a situation. Okay, so sometimes open spaces also you can have, or when there is crowd in the railway stations, okay, or an airport, okay, or maybe a crowded lift, that for that matter. Okay, it's not like the size of the area does not matter at all. Okay, it's basically you are in particular situation, and the patient would have symptoms only in that location, not in anywhere else. Okay, and here the question is that she is scared of people looking at her even. Okay, so it's not written specific areas or or the crowd. Okay, any people, she like the people are looking at her, she get some symptoms, and she had some in restaurant also she had some symptoms. Okay, so it is not at the same place. So point number one. Point number two is that just people looking at her would also cause the symptoms. Okay, so this is more of something known as social phobia. Okay, is it clear?
Yes, sir.
Okay, so in panic disorder, the close will be panic disorder. Panic disorder, what happens is there would be usually it comes in a specific situation. There will be some precipitating factor. Okay, for example, the person is about to give a speech, or the person is about to present in a meeting, or something like that. Okay, in a particular situation where the precipitating event is there, that time patient would have tachycardia, like patient would have palpitation, nausea, headache, chest pain. Okay, those are usually typical of panic disorder. Okay, is it clear? Are you able to understand?
Yes, sir. But like for her to step out of her house is also a similar kind of an episode, no?
Which one?
For this patient, I understand why the answer is social phobia. I have no doubt about that. But to say
Okay,
generalized anxiety disorder, she also has a scenario where she has to step outside the house and she
yeah.
has to
So
go out.
okay, so generalized anxiety disorder means patient has anxiety throughout the day. Okay, both inside the house or outside the house, both. Okay, like she's washing utensils, she's cooking, okay, watching TV. So every act is associated with that some kind of anxiety. That is generalized anxiety disorder. Okay,
Okay, okay. I get it.
okay.